Welcome to this industry symposium from Coloplast entitled New Evidence on Managing the Gap Between the Wound Bed and Dressing. Our speakers are David Keast from Canada, presenting new evidence and consensus reached on managing the gap. Caroline Dowsett from the United Kingdom, presenting new evidence and consensus reached on exudate management and managing the gap. And Terry Swanson from Australia, presenting new evidence and consensus reached on infection and biofilms and managing the gap. Please post your comments and questions throughout the presentations, ready for the Q&A session at the end. We hope you enjoy the presentations and look forward to your questions.
Hello, good morning and welcome to the Coloplast Symposium at EWMA 2020. It's my pleasure to welcome you to this symposium. My name is Geraldine Harkins. I'm the head of the UK wound care business for Coloplast, and I have been in the past a previous district nurse and tissue viability nurse. So I have a very keen interest in the area of wound care and wound management. It's my pleasure to introduce our speakers today. We have Caroline Dowsett from the UK, Terry Swanson from Australia, and David Keast from Canada. So thank you to our speakers in advance of their presentations. Today we're going to be focusing on the issue of the gap that presents itself between a wound and the dressing upon the wound. And what we will do is turn to the speakers for them to help us understand what all of that means in more detail. So what I'd like to do first is turn to Caroline and ask Caroline to talk to us about her perspective of the issue for a patient with regards to the gap at the wound bed.
Thank you, Geraldine, for your kind introduction. It's a pleasure to join you for this virtual symposium. And I guess when we talk about the gap and how we manage the gap, we have to remember that this is about a patient and we need to take the patient's perspective into consideration. And remember that the impact of a chronic wound on the patient in terms of their reduced quality of life. Many of these patients experience leakage and malodor. And when they have leakage from wound exudate, they get pain associated with that peri-wound skin damage. And often that means that there's extension of the wound and further delayed healing. And of course, there's a risk of complications such as maceration and infection. So thinking about the patient, we need a holistic approach to caring for them, which requires us to determine the underlying cause of the wound, identify and treat those underlying conditions or comorbidities that may be contributing to delayed wound healing, and then assess the status of the wound itself using a systematic and structured approach so that we can go on to develop a management plan to treat both the patient and the wound. As well as the human costs, there are significant treatment costs for managing these patients, and that we know approximately 1 to 4% of the total healthcare expenditure in developed countries is spent on managing chronic wounds. So in the UK, we spend in the region of 5.3 billion annually. If we look at the US, that equates to $25 billion. And across Europe, we know that at any one time, there are between 1.5 and 2 million people who will suffer from a wound. And for some of our patients, 15% or more, those wounds remain open or unhealed at 1 year. And the average duration for a patient having a chronic wound is between 9 and 12 months. Some of these patients will have had them a very long time. 17.8% of patients will have had their wound between 1 and 5 years. So, of course, we know more can be done to help us overcome both the human and the health economic costs.
Thank you, Caroline. Really interesting to consider the human aspects of a patient having a wound and the gap that can form and associated difficulties, and also the issues of the health economics associated with mismanagement of a wound and the gap. What I would like to do is ask you now to help us understand what you perceive are the risks associated with that gap formation.
Yes, Geraldine. So let us think about what we mean with the gap. And the gap is defined as the space between the wound bed and the dressing, often referred to in previous literature as the dead space. What we know is that all wounds have unique and irregular topographies, including cavities where fluid may collect, and that can result in the creation of dead spaces. And we discussed the gap challenge at EWMA in 2018, and that resulted in an international publication from that work. And of course, that work continues to be ongoing. So we know there are risks associated with the gap. A gap between the wound bed and the wound dressing should be avoided as it negatively impacts on wound healing. If exudate leaks onto the wound edge and the peri-wound skin, it may become macerated and that will delay wound healing. And in addition, that's very painful for a patient. We know that unfilled gaps between the wound bed and the wound dressing can also lead to increased bacterial invasion and impaired healing as a result of that. And those pools of exudate that collect in the wound can lead to an increased risk of infection and subsequent development of biofilm. So we need to effectively manage the gap to help decrease the risk of infection. So yes, Geraldine, the gap needs to be managed to avoid these complications.
Thank you, Caroline. That's really interesting and helpful for us to understand that in a more comprehensive way. What we need to do is give consideration to the healthcare professionals' perspective on this as well. And in November 2019, Coloplast ran an event that was aimed at gathering consensus about the gap. Coloplast prides itself in the way it would want to work with healthcare professionals to collaborate not just on products and innovation on products, but also on wound care issues. And in 2019, at our consensus event, which was a road to consensus about the gap, we had healthcare professionals from 19 countries who came together to discuss the issue of what the gap does mean clinically. What I'd like to do now is turn to you, David, and ask your perspective of what that event was like for you. What was your experience at that event?
Thank you, Carolyn and Geraldine. It's my pleasure to explain the process that we went through on the road to consensus and a little bit of what happened on those wound care days at Coloplast. As Geraldine has already mentioned, there were 85 participants, wound specialists from 19 countries around the world. It started off with a survey of the literature, and that literature informed the first questionnaire that went out. That questionnaire was analyzed. It was then improved with questionnaire number 2. This then was also sent out, and that also was analyzed to result in 8 themes that we used for use on our wound care days. During wound care days, our 85 participants, along with our expert panel who had informed the process all along, circulated around to these 8 stations. They were given theme questions and they were given sticky notes to apply to the board with their thoughts from brainstorming on these particular topics. Finally, all of those sticky notes were collected by the facilitating group, and overnight they were all collated. As you can see on this slide, there were 8 themes as previously mentioned. Some of the key themes were things such as wound assessment, wound bed preparation, talking about managing the gap, and looking at things such as biofilm. So what did we mean by consensus? In this particular instance, consensus was achieved when more than 80% of the participants agreed. They either strongly agreed or agreed. And even if they disagreed, they agreed to support the particular topic that was under discussion. There were 3 key things that we came up with in this consensus approach. The first was providing an optimal healing environment. The second was that it was important to manage the gap between the wound and the dressing, and that gap management was largely related to exudate control.
Thank you, David. That sounds like a really interesting and comprehensive process that was gone through at the event to create consensus. Now, I also understand, Terry, obviously you were at that event too, and I'd like to turn to you now to ask you your perspective and what you experienced that led to the outcomes from that event.
Thank you, Geraldine. So we've heard from Carolyn about the patient perspective and David about the process. So I'm pleased to share with you the experience and the feedback from the participants. None of us would soon realize how important this type of event would be. We had a unique wound bridge to the road to consensus. As you can see, Carolyn and I up on the left walking over that glass participation. The event was so well organized to provide a positive impact visually, physically, and from an intellectual perspective. We were given instructions and information on how to do the round robin interview process. It was physically laid out with picket fence and each of the stations David alluded to. How exciting it was to see the level of participation and enthusiasm from the healthcare professionals from different countries, different cultures, working united in the quest to improve wound care. Now, I've chosen 3 quotes from the participants and their perspective. The first one was from South Africa. There's always knowledge gaps. This opportunity fills the gap in knowledge so we can have fewer days with wound patients. And from the UK, we were not told, we were asked. It was a very unique opportunity to share our experiences from across the globe. And then from Germany, I think it's very important to gather global experts in wound care and to reach international consensus on clinical conditions such as the gap and the dead space. And that's exactly what we did. From the outcome perspective, what we achieved and what we agreed on was a united and agreed quest to improve our patients with wound cares. There was consensus that the management of the gap is the key aspect of standard of care and for prevention of wound infection. And then there was a 2B, development of treatment guidelines to improve patient care. With this, we'll improve access with the new evidence and consensus of practice to reduce and remove that ritualistic practice and to encourage holistic planned wound care, focusing on the wound healing versus wound treatment.
Thank you, Terry, and thank you also to Caroline, David and Terry for their initial introduction to what we will be discussing in a little bit more detail over our next section. Before I start that, what I would like to do is ask and point out to the audience that you can post questions into the chat function, and we will have a live question and answer session at the end where those questions can be answered by the panel. So in this next section, what we want to do is cover 3 main topics. We want to look at the consensus that was reached about the management of the gap, consensus reached on managing the exudate in relation to managing the gap, and consensus reached on the issue of infection and biofilms related to the importance and relevance of managing the gap. The first point of them I'd like to look at, and I'm going to turn to you, David, to discuss with us and present on the consensus that was reached on managing the gap.
Thank you, Geraldine. We're going to look at a couple of the key consensus agreements in terms of managing the gap. And one of the key areas that we looked at in which consensus was achieved was on assessing the gap. And if we're going to assess the gap, we really need to do a thorough and well-done wound assessment, not only of the wound, but also of the patient as well. And Caroline has already referred to that. When we're assessing the wound, we need to look at the wound depth, whether or not there is undermining or tunneling. What is the topography of the wound bed? What is the quality of the tissue? Do we have granulation tissue, or do we have slough, or do we have necrotic tissue? What is the level of exudate? What is its quality? And what is its quantity? Is it small, moderate, or large? What is the age of the wound? We know from previous research that older wounds are harder to heal than younger wounds. Is there the presence of infection or biofilm? Is this important to our assessment? What are the wound edges? And what is the peri-wound skin like? All of these impact on time to healing. And most importantly, as Carolyn has already mentioned, wound etiology is absolutely critical to understand what is the underlying cause or causes of this particular wound that leads to the gap assessment. Secondly, we reached consensus on why one should assess the gap. And there are some key reasons. One is that we want to provide a moist wound healing environment. We want to reduce the risk of biofilm development. We want to keep the exudate from leaking out onto the edges and damaging the peri-wound skin and leading to increased healing time. We need to look at the decreased risk of infection, and we want to manage this for removing pools of exudate from the wound. And finally, we really want to look at the importance of the dressing and what are the characteristics that we should look for. Consensus was reached on the following. Does it have antimicrobial properties? Will it conform to the wound bed and attach to the bottom so that there is a contour? Does it vertically wick any drainage and exudate so that it does not contact the peri-wound skin? Is the patient comfortable wearing this? And can they get it on? One of the key things that happened in my experience is the patient was unable to provide their wound care because they couldn't get the package open. We really have to look at these kinds of things. And certainly in today's wound care environment, we need to look at cost effectiveness. And finally, we really want to look at promoting that moist healing environment. And all of these are the things that we look for in choosing a dressing. So consensus was reached about wound assessment and the role that it plays, and consensus was reached on the frequency of wound assessment. And it was guided by the triangle of wound assessment, which you can see on the right of the slide. So what we agreed was that assessment should occur at every dressing change or at least once a week. And if you look at the graph in terms of levels of agreement, that you can see that nearly 100% either strongly or agreed with that particular statement. So at Wound Care Days, consensus was achieved through the collaboration of 85 wound care specialists from around the world in conjunction with our expert panel and facilitated by an expert facilitation group. Consensus was reached on 3 key points: the importance of managing exudate, the creation of an optimal wound healing environment, and decreasing the wound healing time. I'm pleased to say that this consensus material reached was collated into an article and published in Wounds International in September 2020. And you will hear more about the series as we continue.
Thank you, David, and for that comprehensive description of the consensus reached about management of the gap. So now what I'd like to do is actually turn to you, Caroline, for you to just present to us the issue of exudate management in relation to the gap.
Thank you, Geraldine. So let us start with what we know about exudate. And exudate is defined as the fluid that leaks from a wound as a result of the inflammatory response. And we know that exudate is a normal part of wound healing. However, it can cause problems when it's in the wrong amount, it's of the wrong composition, or it's in the wrong place. And we have World Union Wound Healing Consensus guidelines on wound exudate assessment and management. And of course, David has alluded to the importance of the holistic approach when we're assessing exudate. If we think about exudate and the gap, the accumulation of exudate in the gap between the wound bed and the dressing is referred to as exudate pooling. And we know that exudate pooling is likely to occur in those wounds where we've got irregular topographies and where we have pocketing or cavities. And exudate pooling can occur when exudate is not absorbed by the dressing, the volume of fluid exceeds the dressing absorptive capacity, or the dressing doesn't provide close contact to the wound bed. And this can result in leaking, strike through, and of course that negatively impacts on our patients. So what's new from the consensus outcome? 93% of survey respondents agreed or strongly agreed that moisture balance is critical for providing an optimal wound healing environment. There was agreement on the importance of that holistic patient assessment and wound assessment, and David talked about the triangle of wound assessment as a tool for that structured process. And agreement that treatment of the underlying cause was essential for effective wound bed preparation and exudate management. The group also agreed on when we should refer the patient to a specialist, and that included when there was lack of improvement in the wound area of less than 20% in 4 weeks, if the patient had increased pain levels or unexpected increase in exudate levels, or where we might suspect that we had an infection or a biofilm or a decline in the patient's health. What else was new? There was participant agreement that dressing selection should be based on an effective analysis of wound exudate and the impact on healing, and that the dressing needs to conform to the wound bed to effectively manage exudate and promote wound healing. And the agreement was that the most appropriate dressing should remove that excess exudate from the wound bed, protecting the wound edges and peri-wound skin, that it should maintain that moist wound healing environment and provide confidence to the patient and security that that wound was not going to leak. And of course, we want our patients to be comfortable, so there was agreement that the dressing should be comfortable for the patient and that there should be an opportunity to engage patients in self-care and supported self-care. And of course, if we have all of that, then we're more likely to have compliance and concordance from our patients.
Thank you, Caroline, for detailing the consensus reached on the management of exudate in relation to the gap. So the third point that we were going to look at in this session was the consensus reached with relation to managing infection and biofilm, and the importance of that in relation to managing the gap. So Terry, I'd like to turn to you to ask you to discuss and present what was agreed in that consensus.
Thank you, Geraldine. I get to talk about one of my favorite topics, and that's managing infection and biofilm. So what do we know and the best strategies to prevent wound infection? Well, as you can see, the diagram on the right is an adaptation from the International Wound Infection Institute, where it talks about the wound infection continuum. So we know the signs and symptoms of infection and biofilm. And if we understand the early signs of wound infection or biofilm, then we can hopefully, through our topical management strategies, prevent the wound from continuing or increasing in the continuum. Knowing the risk factors, which has been talked about previously with exudate management, is important. And some of this information or these strategies is not new in the literature, but what we know is an increased understanding of the exudate and the gap management and the risk for infection. We promote a balanced wound environment through the strategies such as exudate management, which talked about extensively and was great consensus as a priority for this group, that we must clean the wound and the peri-wound, understanding that the proliferation and the migration of the epithelial cells require a wound environment that is conducive to that. That debridement and disruption of the biofilm is essential. It's a cornerstone of preparing that wound for the dressing. And then we need to follow that up with proactive topical wound management. And then we need to keep that cycle of assessment going that Carolyn talked about, and that's identifying and managing those host factors. So why is managing the gap important? And these are some of the key findings from the consensus project. And I will focus mainly on wound infection. So when you manage that gap, you decrease the risk of infection. And then if you do that, you also decrease the risk of biofilm formation by managing and wicking that fluid through vertical exudate management and preventing that cascading onto the peri-wound. You decrease the inflammatory, you remove that excess exudate, which we know is pro-inflammatory. And the clinical success factors for managing that gap is managing that bile burden. So when you have that vertical wicking and that absorption into the dressing, you also have that sequestering, therefore decreasing the bacteria's ability to proliferate within the wound. So what are the new insights, the consensus we reached on how to prevent that wound infection? We agreed that the best prevention strategies are the following, and that's effective debridement and wound cleansing for the reasons that I've talked about in the previous slide. Managing that exudate by managing the gap between the wound and the wound bed dressing. Each time you do a wound dressing procedure, it's an opportunity and a responsibility to assess for signs of infection. We recommend using the IWI Wound Infection Continuum signs and symptoms. And anytime that we use antiseptics and antimicrobials, we need to have stewardship. They need to be used appropriately for the right time and the right amount. And then we need to promote a sterile or aseptic environment, prevention of cross-contamination through hand washing, antiseptic use, and ongoing patient education. As you can see from this photo, the top is immediately after the dressing has been taken off, that you have a lot of gelatinous substance on that wound. You have maceration at the wound edges. The lower photo is post, and this is what we need to do to prepare the wound for the dressing that we're about to put on, showing that the topography of that wound is not even. So using that dressing that conforms to that will provide the components that we want to have to prevent wound infection.
Thank you, Terry. Really interesting, and very interesting for people to understand just how significant the management of the gap is in relation to infection and biofilm risk. And thank you to David, Caroline and Terry for your comprehensive presentation of that road to consensus about the gap in relation to exudate and, as I said, infection and biofilm risk. Just to reiterate what David and Terry and Caroline have mentioned through this is that there is a publication, in fact a series of publications, 2 of which were presented in September and 2 of which are coming next month in December. These are available at our booth and will be available for you to download at our booth. Obviously the ones in December not yet, but the first 2 are. So please do visit our booth and have them downloaded. So now what we're going to do is head over to our question and answer session, where we will pose to Caroline, Terry and David the various questions that have come in while we're presenting the symposium. So over to our questions. The first one I'd like to pose to all 3 of you actually, but start first with you, Terry. The gap, often referred to as dead space, is known from literature with a number of publications on the issue. So when reflecting on the findings from the consensus process that we went through, would you say that this is new evidence or more a consolidation and summary of existing evidence? Terry, you're muted.
Thank you for the question. Sorry about that. This is not new information, but what is new for us was that these wound clinicians from around the world had a consensus that this was important. We know in the last 10 years that exudate management, that vertical wicking, is so important for that microenvironment. So it has a renewed level of importance and priority that when we're doing a wound dressing procedure. So it is a consensus that it is one of the key priorities for management of a wound.
So I think what you're describing is it's almost like not new, but a new perspective, a Correct. New way of considering it and thinking about it. And David, what's your thought on that?
Well, I think one of the key issues here is that we finally put all of this together in one place. And it's organized in an organized approach to managing the gap, and particularly focusing on exudate and the role of the dressing in managing that exudate. So I think that this may, in fact, collating all of this, be new information for some clinicians. For expert clinicians, they've always known this, and hopefully what this does is reinforce the approaches that we've all taken in the past to manage this key issue.
Thanks, David. I think that's a really important point to make, that we may know things, but does everybody else? And how do we make sure we convey that? Caroline, have you got anything you're thinking about with this?
Yeah, I think, I support Terry and David's comments, and I think you have to remember that some of this is quite intuitive to specialist nurses, but we know from the patients we get referred that there are ongoing problems around not assessing the gap, not preventing that gap between the wound bed and the wound dressing, resulting in complications for the patient, which affects their quality of life, and of course the wound, which delays wound healing. So I think we have learned some new information, and I think the road to consensus was very exciting to bring people together as one voice, really. And for me, it was about clinicians working with clinicians, and these are people who are at the bedside every day, so they know the realities of clinical practice.
May I just add one more?
Oh, sorry, yes, go, Terry.
For those who have been in wound management for a long time, we remember that we went through that era of overpacking, that dead space. And so now we have a renewed understanding that if our dressings can contour to those areas, that we're not causing harm within that by overpacking that dead space. So we fill that gap gently. And so it achieves what we want to do with exudate management without causing harm.
Yeah, that's a really good point, because I think we will all remember the days where it was almost a competition to see how much packing we would get into a wound, which clearly was not good and we've moved away from. But the contouring component that you discussed is really, really relevant, which actually leads me to the next question I have really nicely, because it's a very clinical aspect to this. So how should the findings that we've been discussing and you've been presenting influence or change clinical practice? And if I come to you first, Caroline.
Yeah, I mean, I think there are lots of different guidelines out there, aren't they? And I think this is different from my perspective, because being present at the wound care days, where you felt that energy and that call to action to really go back and change practice. And I think when you get that many people rooted in clinical practice together and they commit to that, I think there's great potential here for us to, it's a bit like train the trainer, isn't it? You know, we have this information, we now will have the guidelines and the tools to operationalize change. So I think I'm expecting great things to come from this, Geraldine.
Great. Terry, is there any other reflection you have on that issue?
Yes, I think what makes this consensus journey different is that we really did have so much different disciplines. So we had podiatrists, we had surgeons, we had physicians, healthcare educators, nurses, and physicians. And scientists. So it was really a cross section, all levels of education and all types of practices. So it really fed in from the academia and science down to the coalface, the everyday clinician, and providing that consensus. So it really was a well-rounded and full-bodied approach and conclusion.
Great. So people like yourselves, leaders of wound care services, are able to then use this to help support giving information and guidance to people that you are overseeing. David, I wanted to come to you and ask you a question. How would you suggest handling the issue of undermining or tunneling that kind of gap formation?
That's a really good question, and there's been a lot of debate about how one handles things such as tunneling, and in some instances people are saying that we should never put any kind of wicking into that particular tunnel. Some people say we should, and I think the key thing that we've learned from this is that as much of the dead space as we can possibly fill, it's important to go ahead and do that kind of thing. But as Terry has mentioned, we went through that era of overpacking. And personally, I don't ever use the word pack because people take it as a challenge. And we've used things such as gently fill or fluff, don't stuff, those kinds of things to get people to ensure that the dressing contours to the wound bed and removes that exudate into a secondary absorber or into the dressing itself, so that we reduce these risks of non-healing. So it really is important to assess for that, to find it, and to try and manage it appropriately. And another word about tunneling, please don't put anything down there you can't get out, because a lot of us have had the experience of having to find at a later dressing change that we're pulling pieces of packing out that were missed some time ago. Here again, if we can do this in a uniform way with the dressings we choose, it makes it much easier on the clinician to be careful about these things.
Yeah, thanks, Dave. That's really good advice. And I love your expression, fluff, don't stuff. That's a good one. Terry, there's a question come in that I'd like to pose to you. Is it recommended to cleanse and debride before dressing?
Yes, it is. You always have to prepare the wound. And anybody who's come across any information from Thomas Barnholt, Greg Schultz, Randy Walcott about biofilm, understanding that because of the phenotype of the biofilm, it does require that disruption, and that requires debridement, whether you do that through cold steel, whether you do that through curetting or aggressive cleansing with the moistened gauze. Then you follow before and after with the IWI suggests an antiseptic cleanser for those wounds that are hard to heal, that aren't healing. And then that prepares the wound bed, understanding that for the hard to heal wounds or wounds with biofilm, you can't miss a step. So you have to cleanse, debride, get those edges, all the crust off, because that's where the proliferation and the migration comes. And then you have to do a proactive management with that dressing. So you want to, and we know since late 1990s that microenvironment, that chronic wound fluid is pro-inflammatory. So making sure that excess exudate is wicked away, but leaving enough so that you have that optimal moist wound environment.
A great descriptor of what you've done. And I love the one of remove the crust, because so often that's seen, and especially generalist nurses are not so comfortable necessarily with doing it, but it's so important. Caroline, a question's been, it's evident that management of the gap is crucial to successfully manage chronic wounds. In regards to biofilm control, do you think silver is good enough, or are alternatives required?
Yeah, I think, as Terry said, this is about the holistic management of a patient, isn't it, as well as management of the wound. And I think there are a range. I think the important thing is wound bed preparation before you select your dressing. So that cleansing and debridement that Terry has mentioned. And of course, there is a place for different types of antimicrobials in the wound environment. And I think often our selection is based on our formularies and what's available to us. So sometimes those decisions are taken out of the hands of generalists. And I think our sort of mission really as specialist nurses is to really be able to consolidate the evidence so that we make sure the right products are available for clinicians caring for patients. So I think on our formulary, we've got a number of different antimicrobial dressings and solutions available.
Yeah, thank you, Caroline. David, you talked about the age of the wound in your presentation and it being important to assess. Can you elaborate on what you're meaning by that, please? And what does current research and evidence tell us about that?
Well, actually, the evidence on the age of the wound and its impact on wound healing goes back a very long time. And in particular, they started to go back when we were discussing things about venous leg ulcers. And there was a lot of good research that was done probably about 10, 15 years ago, looking at the age of venous leg ulcers and the relative healability of these particular wounds. And it was clear from the assessment of a large database of wounds that the more recent the wound, the more likely it was to heal, and the longer it was around, the more likely it was to not heal. And so the evidence for that has been around for a long time. And so it really behooves us to try and ensure that when wounds are young, that we get at them when they're at their most healable, that we do that thorough assessment. We look at the underlying causes. We look at what's going on in the wound. We look at managing the bioburden in these, all of these things to keep them from becoming chronic, because once they become chronic, they then become very difficult to heal without significant intervention.
Yeah, very true. Thank you, David. Another question's come in that actually I'll direct to you, Terry. Your real interest, you said your passion is around infection and infection management. So this question relates to something around that. So what antiseptic solutions should be used to cleanse the wound?
Again, I'll go back to the recommendations in the literature, and the latest evidence is that surfactant antiseptics are very good at assisting with disrupting, or the more modern antiseptics are less cytotoxic. If you have none of those, then the older ones that do have some cytotoxicity to them can have some efficacy, but you have to remember to use them for a short duration and rinse them off. There is a lot of debate in the discussion about clinicians about getting patients into shower. And again, it goes back to that holistic assessment and the risk management. So sometimes we will use something that has a bit more cytotoxicity when it's grossly contaminated or infected, or allow them to get in the shower for a particular reason. So everything that we do, remember, you have to target and individualize it for that wound and that patient. So there are different parameters, but if you don't have the antiseptics, make sure that you do the mechanical cleansing to disrupt that biofilm, and then make sure you have good exudate management. But we do like to have that therapeutic cleansing using some level of antiseptic coverage.
Great, thank you, Terry. Over to you, Caroline. During your presentation, you mentioned that dressing selection should be based on effective analysis of wound exudate and the impact on healing. Can you tell me about how you, from your clinical perspective, analyse exudate?
Yeah, so I think, going back to the presentation, listening to David and to Terry and what I have said today, it's important to remember the holistic care of the patient. So when we think about exudate, we think about it within the context of the holistic care of the patient. And in the organisation I work for in London, we use the triangular wound assessment. So we have a systematic assessment process that includes assessment with management of wound exudate. So we look at the amount of exudate coming from the wound, we look at the type of exudate and the consistency, because that can tell you a lot about what the problem is. So if we think about that general assessment, I think about patients I see in the community who have lower limb edema, or they might have venous insufficiency. They're not going to bed, they're sleeping in their chairs with their legs dependent. So that's obviously going to cause a problem with leaky legs. And you need to think of the bigger picture in terms of the management of that patient. And then I think we have to think about the effectiveness of our current interventions. So I see patients come to the dressing clinic and they've got leaking wounds, but the reason that the wound is leaking is because someone's choosing to put the wrong dressing on the wound, and the dressing isn't managing that exudate. So I think it's about looking at the bigger picture, the holistic care of the patient, then looking at the volume of exudate, the type of exudate, and the impact it has on the patient. And of course, some of the things we see in clinical practice is that maceration, extension of the wound, patients suffering unnecessary pain because we haven't done a good assessment of the patient and the exudate.
Thank you, Caroline. Some really good points you've made there, and relate into something Terry talked about earlier too, which is of course about vertically absorbing exudate away and the dressing conforming to the wound bed, and therefore protection of the surrounding skin to minimise issues of maceration, etc. But assessment being key in that whole process, of course. I'm going to come to our final question now, and actually would like to ask each of you, and David, I'll come to you first. I'll have the gentlemen before the ladies first. what was from your perspective the key reflections and outcomes from the consensus project on managing the gap?
Well, I think my first reflection on this is the thoroughness of this particular process. And I think I tried to address that in the earlier questions that we had. So well-developed questionnaires informed by an expert panel, fed out to our participants for wound care days, and their opinions brought back, and that developed the themes that they did on wound care days. The second thing that I think I would comment on was the collegiality and the cooperation and the consensus that was agreed. I mean, look at the slides and you look at the levels of agreement, over 90% agreement on certain statements. I mean, I think that's pretty remarkable. And I think that's what's key about this particular process. We've known about the dead space. I particularly was involved in a publication nearly 20 years ago on this particular topic. And so consequently, what was really new about it was the consensus among a wide group of people on what the key things we need to do to examine the gap and to manage that gap.
Thank you, David. Terry, can I ask you the same question?
Yes, thank you. It's a good question. For me, it's that emphasizing not only what David said, but that with each dressing procedure is your opportunity to assess, to determine, is there signs of infection? Was the last dressing appropriate? Did it meet the need? As Carolyn talked about, that some of the problem is that the dressing isn't appropriate. And then doing all the steps for wound bed preparation, and then putting on the appropriate dressing based on a multitude of factors. So that was a great emphasis. Understanding that the right dressing can save money and time. So it really is a remarkable effort to go back to the basics and have renewed emphasis for that exudate and managing that gap in a safe and appropriate way.
Thank you. And Caroline, the same question to you.
I mean, my reflections are what an amazing process it was to bring people together and to be able to do what we did in such a short period of time. My experience of bringing surgeons, podiatrists, nurses together is you don't always get consensus and agreement, although you do get some great discussions and dialogue going. But what we've done here is we've reached consensus, as David said, high consensus agreement in some of the topic areas. And I think we've gone on to publish this work. And I've never been involved in anything that has gone with such speed and such precision. And I have to say it's been an absolute pleasure. But for me, as a clinician, the next bit is the implementation. And I think that is key to making this a success, because we mustn't have done all this great work and now not make a difference to our patients. So I think I'm excited about the next part of our journey.
Thank you, Caroline. Thank you for that excellent question and answer session. Some great questions from you, the audience, and some great responses from our speakers. And a final thank you to our speakers, Caroline, David, and Terry, for their really great presentations over this last hour. What we have done is worked really hard to collaborate with healthcare professionals from across the globe. Our road to consensus, looking at the issue of the gap between the wound beds and the dressing, was a process that we pride ourselves in doing. Coloplast works really hard to interact with clinicians on wound care issues and on products. So much so that actually we are seen as leaders in the industry, setting the standards for this process. And we have won an International Facilitation Award at a platinum level for the work that we did through that process. So the road to consensus on the issue of the gap between the wound bed and the dressing itself was one that we set upon to find out, is this an issue? Is this a clinically relevant issue? And there is no doubt that that is the case. We had 19 countries represented, 85 clinical specialists in wound care, all collaborate and discuss this issue and have agreed that managing the gap is one of the best ways to provide optimal wound healing. And it's really important that dressings used conform intimately into the wound bed to minimise any issues of gap formation. During that process, we learned such a lot. We learned that there were so many insights that we needed to follow up on beyond this single project itself. And what we learned was that treatment guidelines would be highly valuable to help clinicians internationally in managing the wound and how to manage that wound in a very practical way. So what our next step is to collaborate further. And our intention is to collaborate with over 2,000 clinicians across the globe to pull together treatment guidelines. And those treatment guidelines we intend being ready during 2021. So a final thank you to everybody for attending this event. Thank you to our speakers again. Thank you to those of you in the audience. And we would ask that you do go and visit us at our booth. We'd love to see you. We will be able to provide you with printouts of the articles that we discussed earlier in the presentation, and also provide you with information on our products. We have an excellent range of products. There is no doubt that the issue of the gap is a clinically relevant one, and management of it is really important to optimise wound healing. We're all working in really challenging times, and what we do hope is that you have gained from this symposium, you've enjoyed it, and that you've been supported with some clinically relevant information that maybe just provides you with a new perspective on the management of wounds and management of this issue of the gap. So good luck in taking that back to your place of work, and stay safe in such difficult times. Thank you.